about the early treatment we can, because the preventive or maybe early orthodontic treatment is a hot topic that some clinicians have strong advocate and some no, wait. That's been against debate into two groups. The question comes from, can we truly prevent development of a malfunction? My approach for the following patients comes from a balance of story, basic knowledge, and research, and clinical experience in treatment of the following patient from when I pediatric dentist until I jump into the orthodontist. And then from the mentorship of the more experienced clinician that I deeply respect from my country and internationally. That's been we combine that and to make this approach for the growing patients. Next step is we jump into the side behind the Invisalign for the growing patient. When I have experience to read articles about the medicines, we treat the organ not individually. That means you don't, when you have someone about your hand, you don't treat about your hand. The doctor should treat to evaluate another organ that's involved. That means it's about the growing patient. When you want to evaluate the malocclusion, you have to look into 4-dimensional beings of the patient's time, because the growing children is the time is a critical factor in your treatment. Time is the 4th dimension. That means age is too late. That means I recommend age 7. For the early class 2 treatment in the growing patient, I begin with malocclusion in the early. In this case, come to my clinic with the problem about the protrusion of the upper front teeth. You can see that they don't have any abnormal habit, and the upper front teeth is more protrusion, is shown to class 2 malocclusion in the growing patient. And we can see about the arch form. It's like the omega or conflicting arch form, and the lower arch collapse and clouding. That means for the upper arch and lower arch is like the box with the lid. When the lower arch wants to uplight, it cannot because the lid is constrained. That means you have to evaluate about this phenomenon in the young children. When I look into the panoramics, you can see that there is a problem about the upcoming teeth, especially upper permanent canine. And then when you take the central matrix, you can see that patients still in the cervical vertebral maturation is a younger as CS2. That means more than 2 years to go to the peak of post-birth. That's why patients come to, because they have a problem about to make the lips, to bring the front, the upper front teeth back. So we use Invisalign first for this treatment. You can see that we have, this is the twin shape from the treatment. We expand the upper arch and lower arch, and then we use the Invisalign first with the mandibular advancement to help guide the lower jaw forward. Okay. This is a 6-month of transformation because this case has a problem about the compliance. I use this case for the first case of my presentation because I want to give a knowledge to you that when you want to treat the younger patients, you have to make like a behavioral management in your practice too. Because if you have a good treatment planning, but the patient refuses to use this appliance, it's not work. So I make negotiation for this patient by, okay, especially you already know that the patient choose where Invisalign at least hours per day. How many? 22, right? That means for the children maybe up to 20. So I negotiate with the young girl with less compliance, just only 10 hours per day. But I explain from the 7 to be 10 days per set. That means this is the negotiation. And then when it comes in each month for the appointment, I evaluate about the oral hygiene instruction and I make a positive reinforcement. Like, wow, you have a better looking about the country and then you look beautiful. And then after that, I make improvements about the timing of wearing aligner into the same as the adult or maybe adult patient. That means this is the technical in your behavior management in younger children when you treat about the mouth occlusion. This is a 6-month transformation. You can see that the arch form is better. And the clouding in the lower arch try to solve by Invisalign first. And this is a 12 months of transformation. You can see that we can reduce the upper front teeth protrusion and expand the arch. You can see the arch form. It can round about. It can make a better, it's wider, and make a room for the space in the reduction of the front teeth. And you can see that only in 1 year, in the lower arch, almost complete alignment. And this is the final result of the phase 1. You can see that after that, patients, we could not get the my objective ultimate outcome in this case, but we improved. And because the various factor in this patient about the compliance, so we stopped for the phase 1 and follow up the patients because the patients and the parents satisfaction about the result in the phase 1. Okay, I stop and follow up the child for the next time to move to the phase 2 treatment. And this is the final. You can see that we have made a room space and correct the lower arch cavity in the phase 1. And this first smile. And you can see that from the panoramics, the upper canine has a room space to elongate into the oral cavity. And then it's time for me to follow up the results. Although we don't push the overjet in the less than I want to, but because the limited factor in this case, you can see that it's the improvement in the occlusion and the profile, especially in the upper front teeth. Another case for the class 2 collection, about a 9 years old girl. The same question comes from the retrographic mandible and the front teeth like a protrusion, and he cannot make the lips close together by naturally. That means it's called completely potential lips. And there is a lot of the spacing between teeth that this is a no problem about the space condition. When we saw the OPG, we have number of the teeth is in the normal number though, and we evaluate about the facial pain. You can see that about the frankfurt, the occlusal pain and campus pain is so different. So about the same as the previous case is about the younger child. That means in CS2 stage about the skeletal age of her patient. This is the asset. So the problem is we went to treat the mild skeletal class 2 and slightly retrographic mandible, hypodermal pattern, upper one and lower one severe inclination, and mean large overjet. planning, we want to correct the class 2 malfunction, correct the anterior protrusion, and achieve ovite overjet with proper and midline coincide together and provide space for the upcoming teeth in the future. And the final objective that I emphasize on every going patient is about the obtain the neuromuscular equilibrium of the soft tissue. If you don't treat this girl, the lower lip will trap in the back of the front teeth, upper front teeth. That means the population will reverse more and make the casting more severity. So when we make the upper front teeth come into equilibrium, the upper lip and lower lip can cross normally. That means you have improved about the oral neuromuscular equilibrium of the child. This is a print check. You can see that we also make the proper arch form, and then that means the expansion, and then we have a Invisalign with mandibular advancement to jump the mandible forward. Then to give the proper ovite overjet. And then this is the tooth number about the tooth movements. This is the staging. You can see that everything starts together. And ovite overjet before. And after that, you want to get, this is the progress of the case. You can see that the overjet, and especially in the front teeth, slightly track. This is the arch form, upper and lower arch. This is the comparisons, both upper and lower arch. After that, we use the additional aligner because this case has a problem about the engagement about the precision ring, and we make a new one, and then jump again. With the goal of the same objective of treatment. You can see that from the process of the aligners, the interval change. When we want, for the first step, we want 53, but we got just only 49. That means aligner not give you 100% that you get. You have to overcorrection. You have to make another set for the child. This is the second step. You can see during use the mandibular enlargement stage. If you have some of the permanent teeth erupt into the oral cavity, you can use the auxiliary technique to bring the canine into the occlusion by using elastic, and you cut the aligner and use the elastic to take the teeth into the oral cavity. You see that this is the progress of you use your elastic nail in the upper canine to jump into your alignment. And this is a technique that we have used elastic to cut and put the bottom to bring the canine into the oral cavity. This is small. This is almost finished. You can see that the problem about this case is that because the occlusion changed, we cannot get the coincide together of the midline, but we reduce the overjet, we reduce the overbite. So this is the comparison between before, which progress, and almost end of the phase 1. The arch form changed from the auricular arch form to be the symmetrical parabolic arch form, and plenty of space for the upcoming teeth, especially premolar and canine. This is how we compare about the lateral profile of this patient when we treat in phase 1. You can see that she improved with with about treatment. And this is the OBG before the end of the phase 1 treatment. After that, we wait for a phase 2 treatment for the upcoming of the pendulums, and then we have to really scan and make a phase 2 treatment in the future. Another case, a young child, 8-year-old, she has like a double chin, this means like a fat girl, chubby girl. You have to evaluate because the too much fat doesn't mean it's camouflage about your skeletal problem. So when you see in the oral cavity, you can see that there has like a auricular in the upper incisor and auricular arch form and crowding. That means we have, this case is the about the cooperation is not good candidate for the patient, but the parents want to treat. So it's my trouble about me. So we evaluate from the upper canine. You can see that the raw axis of the eruption is maybe still problem. We need to pay. And then you can see from I already told you that soft tissue may be camouflage the skeletal problem in this case. You can see that she has slightly traumatic mandible, that means she has skeletal class 2. When we evaluate about the skeletal age, also not reach the pivotal growth spurt, and then we have to make a problem list from the test. It's mild skeletal class 2, slightly traumatic mandible, normal divergent canthal. Upper is called wing, like a butterfly wing incisors, and mild class 2 malfunction, and moderate cavity. So treatment plan, we want to collect not about the dental problem, we want to know about the relationship of the maxilla and mandible by correct class 2 malfunction, correct anterior protrusion, correct the auricular crowding in the upper and lower arch, and got the midline of inside together. And finally, we got upper arch form and obtained neuromuscular equilibrium for the soft tissue. This is the kin shape. You can see that. Mostly for the younger patient, you can see that we have to do dental alveolar expansion by Invisalign first, and then we use the feature about the mandibular advancement to jump to collect the anterior-posterior relationship of the jaw. In this case, it's an example about the staging. You can see that move our teeth together, and we want to collect a biojet to be open. This is the progress about the 5 months. You can see that alignment of her teeth is really better, right? You see? And then, because why don't you treat caries problem before you treat orthodontic treatment? This is an exceptional case I want to show you that when we saw in the OBG, there is a root break that cannot treat by powder treatment. We need to extraction, but because this young girl is a nephew of the Prime Minister of my country, so she has a child that parents don't want to extract at that time, so we have to follow parents' instruction. That means we follow up about this kid, okay? And then you can see the progress of the treatment. We have overcorrection to be the HTH bite. You can see when we jump the mandible to be HTH bite, what happens? Posterior open bite. Don't worry about this. It's about the overtreatment. That means we want to overcorrection about the treatment in 9 months. And we create a lot of space for her to align the teeth and to make the arch form broader and bigger. For 12 months, the O-by-O-J is improved. That means the posterior teeth try to come together to bite. This is the arch form. And this is the iris scan for the next. The problem with traces is that curve of stay in the lower arch still high. That means we want to include the lower anterior, lower incisor teeth to be the flat as much as possible. This is from the iTero scan. We make an additional alignment for her. You can see that we want to jump the bite and make a proper O-by-O-J and get the proper occlusion in the posterior. And staging, you can see that move our teeth all the time. And this is the O-J. Take a long time because the cooperation is less in this case. And then you can see we got a proper space for the alignment. And we have to expand more. And this is the final when we finish with the first phase of treatment. You can see that we got the proper O-by-O-J and midline coincide together. And the posterior teeth come to contact. That means we make a class 1 in the molar area and make O-by-O-J and midline coincide together. This is the objective of the phase 1 treatment. This is the final for the phase 1. And you can see that, go back to the slide. The problem is that it's gone. Okay. Another case is a young, in 7, almost 8-year-old. Also come with the class 2 retrographic mandible too. You can see that. This is the example that she is the sister of the previous case. The problem of the teeth is different, but in slightly class 2, this is a retrographic mandible, obviously. And then we have to create the arch form. And also in CS2 for the skeletal saturation. The problem is also skeletal class 2, retrographic mandible, hypodivergent pattern, upper one and lower one proclination, and class 2 malocclusion, but there is a lot of spacings, especially reclusive of the lower lips. And this is a treatment plan. Also, we treat the patient in 3 panes of space, transverse first and anteroposterior to include the vertical dimension that we have to evaluate. That means the treatment plan also the class 2 correct the class 2 malocclusion, correct the anterior protrusion, achieve the proper O-by-O-J and proper incisor angle and midline to coincide together, especially proper arch form and restore the neuromuscular balance of the child. This is her clean check. You can see that we expand both upper and lower arch to make a proper arch form. And then after that, we got the mandibular advancement feature to jump the mandible to coincide with the upper arch. Then we got the objective that we want. This is a stretching that we want. O-by-O-J before treatment, dental arch form development. 5 months transformation. You can see that in this case, we want to try to retract the upper slightly and forward the mandible. This is the 5 months, the lower arch. The 6 months, the 10 months, you can see that when we jump the mandible forward, what happened? Posterior open bite. Don't worry about this appearance. After that, when we collect the anterior contact, it will be into the posterior occlusion. And then we do scanning for the additional aligner. This is the example for the timing. We also expand for the upper arm to get the proper arm form. Don't worry about your expansion because aligner have is called aligner deformation. That means you want 100%, and aligner can give you just only 50 or 70%. That means we have to overcorrection of the expansion. And then we do staging or by order change. And dental arch development, that means we expand more. This is her almost final. You can see that we create space for the upcoming, and this is her final because a lot of space for her coming and proper OBIOJ and midline coincide together. This is her arch form in the finishing in the phase 1 treatment. After that, we use it's called phase 1 Hallway retainer. Yes, after that we want patient to come to regular check-up for the 3 or 6 months to use it. To check for the upcoming, maybe some thing loose, maybe to check that permanent teeth that comes into the oral cavity has a problem about the retainer or not. This is the place. You can see that every child, when you treat in the younger child, and when you finish, you can see that there is a lot of the improved, right? You can see how improved teeth grower. That means teeth more beautiful profile and proper OBIOJ. Another case is example to show you that when we treat in phase 1 treatment and we follow by the phase 2 to finish in the permanent condition, how is the case? This is the example. Come with the almost 9-year-old. She has a problem about the lip bite and upper front teeth protrusion, and her friends call her horse teeth, so she wants to treat early as possible. This is her problem. It's lip bite. You can see that curve of speed is over eruption. That means you have to treat by and we see the cut down and stage of the growth. Just means you have to treat the suitable trajectory. This is a cell. And then this is the print shape. You can see that during the mixed condition, we also corrected and upper front teeth and the lower front teeth and jump the mandible forward to correct the lip bite and anterior-posterior relationship. This is her progress. In this case, there has a problem about to wear the aligner too because she don't wear almost 72 hours per day. So there is a progress of the treatment in 3 months. And then I stopped and rescan because there's a problem about the fitting. And rescan and make the same protocol for treatment. And there's her 13 months. The system protrudes, but less is improvement in her upper front teeth protrusion. And in our 1 year, you can see that we have to open the anterior. That means we have to collect the lip bite better. 15 months. Better, but the midline not still coincide together. This is the clean shape, another clean shape. You can see that 16 months. Okay, you can see that OBIOJ is improved, but the midline cannot improve. Why? Because when the patient bite on the precision wing of the Invisalign, maybe the wall bite at one side, maybe make the mandible wing differently. So this is the problem you have to evaluate and correct. For this case, progress almost 2 years. You can see that I jumped from the phase 1 treatment into the phase 2 treatment. That means we have to implement about the permanent teeth into the treatment. And then I do additional aligners to make a proper arch form and proper posterior occlusal interdigitation. You can see that we have a significant jump in this case and use elastic to help. This is almost 2 years later. You can see that the progress is better. I gain the midline coincide with the back. Okay? That means I can do the proper arch form in the posterior. And another AA to get the final occlusion with the best outcome. You can see that it is the progress. The progression, you can see that. Overhead reduced and midline coincide together. Posterior twist has good interdigitation, and then I have another one to get the final result with the best outcome. And this is her final. This is her smile. You can see that this is her final occlusion in the permanent dentition. You can see we can get midline coincide together, proper or by overhead, good alignment of upper and lower arch, good arch form. And especially when you treat admission from the younger child to be the full permanent dentition, you don't need to extract permanent teeth. And you can get proper or by overhead and good arch form, proper profile of the patient. But we have and put about the condown. That means we balance about the neuromuscular include the 3MJ. And then we check and comparisons when we treat in phase 1 treatment and to be in the adolescence, we can see that the improvement in her facial. That means we have treated from the deep bite, this dentition to be the permanent dentition. You can see is improve everything. And then this is the arch form from mixed dentition to be the permanent dentition. This is her profile change from her child to be adolescent. She improved about the aesthetic about the profile. Another case. This is her son of the dental doctor in my country. This is my first case about the Invisalign with the mandibular advancement in the team. I treat with the purpose that mother don't want to extract any teeth and improve the lateral profile of her son. So I use Invisalign with FA. You can see that the arch form and protrude upper front teeth and the crowding in the lower arch. You can see that. And I treat 6 months progress. This is our permanent. We expand the upper arch and lower arch. And then 10 months, you can see when you jump the mandible, there has an ancestor interference. There will be a posterior open line in case that you want to jump the mandible forward. Don't worry about this. You will collect them by the additional alignment. And then you can see that when we scan, we collect them by the additional alignment. It is the discrimination of the occlusion. You can see that after that we got the final outcome with the good interdigitation of the posterior teeth. That means it's a stable occlusion. Okay? This is the comparison. Initial, progress, and the final outcome. The final case of the class 2 malfunction with the mandibular advancement technique. This is the child, is the older child, that means maybe 12. That means we have to use the Invisalign in the adolescent decline because it deep bite and protrusion and slightly hypocratic mandible. You can see that. And have a reverse curve of spin. This is a twin shape. The same protocol. Expand and retract and jump the mandible forward. This can help in correct the class 2 malfunction, especially in the adolescents. That means the progress of this treatment. Great. You can see that. We have to emphasize. I told you that when you treat from the child to the adolescents, you will have a problem about the oral hygiene instruction. Because when the patient to be adolescent, he has something new to focus, like a game, like a chatting, anything else. From the good oral hygiene to be the friend or be the poor, that's when you have to emphasize about the oral hygiene instruction in the adolescents when you treat the tree. For this case, we use Invisalign with MA, and you can see that on the progress of the 9 months. The oral hygiene is not good. You can see that there is a lot of the gingival inflammation, right? But we got improved in the oval shape, but we have a problem about the oral hygiene. And then we try to testify about the full line mouthwash and send them to the periodontist and periodontist to help them to collect about the oral hygiene problem. Then 14 months. You can see that when you jump over correction to be edge to edge, what happened? The same posterior open bite. Don't worry about this. You have to collect them by additional alignment. This is progress 2 years. You can see that the posterior teeth come into the occlusion, and this is his finishing of the case. You can see you can got the proper bite of the teeth, and you can got the good interpretation and got the class 1 malfunction in our. That's means this is a comparison before and after. That's means this is the case. The profile change. You can see that. The final case of the class 2 treatment in the team is not about the class 2 with the MA. We use the class 2 with elastic for this boy. It has a problem about the protrusion in the class 2. You can see that upper front teeth protrusion and more in class 2, slightly class 2 and on, and have a reverse curve of space. That's right. And then we scan. We have a problem. You can see the OBG. Can you see the problem in the OBG? The lower left second molar impaction. You can see it in the slide. That means when you treat, this is the problem about this case. When you see the case like this, we treat by Invisalign. You cannot include the plastic into the impacted teeth. That means you can see in the print shape, we don't involve lower left second molar into the case. Okay? Then we do the extraction in the upper and lower arch, and we track upper front teeth back. The biomechanics that we want to expand, when we expand, the upper front teeth has a space to retract. Also in the lower arch, this is the the problem. How? We left this one in the problem. We treat just only treat that we lock into the oral cavity? No. We use auxiliary technique. We use microscope to help in this case. You can see that this is the progress of the microscope that to push the impaction back. And then we use aligner together with the auxiliary technique. This is progress. This is the comparison to show you that in the lower arch, you can see the lower left second molar impaction, and then 4 months is better. The angulation is better. And the 7 months, I almost saw the opposite table of the lower left knee to lower left 7. And then for the 9 months, I can see for the opposite table. This is a focus on the impaction on the lower second molar. You can see that with the easy technique we have added in during the treatment in this line, it can help. After that, we scan to include the lower left second molar into our fine plan. That means for this clean check, you can see that it can include the lower left 7 into our treatment plan. That means it's better. Okay? Almost 2 years, we got the proper obiotic in the front teeth, and we got the almost finishing in the lower left area. And I do more in the additional alignment. You can see that. Okay. We want to make the lower left 7 more into the occlusion. That means we want to exclude them to make a proper occlusion. This is the progression. You can see that almost finished. We got the proper occlusion, and then progress, finish. You can see we got the proper obiotic, and the problem about the lower left second molar has already solved by auxiliary technique with many screws. Okay? Then you can do that. It's very easy, because I know that everybody can do that. But we have to make a biomechanics to get it. You can see from the OBG, from the lower left second molar enough into the occlusion without interfere with the third molar. I don't prescribe the patient to remove the third molar. You see, the lower left third molar still present. You can collect the angulation or maybe the impaction of the lower left second molar into the normal occlusion without the remove of the third molar, because he is still in the golden child. You can treat anything. Okay? This is a comparison. This is a set comparisons. And you can see comparison from the OBG. It's really obviously to see that there is a huge change, remarkable change about the angulation of the lower left second molar impaction. This is but we take a time too much about to this like this. Okay. You have to use various techniques of the Invisalign treatment, include the patch into your treatment plan too. the rest of the first part we jump into the class 3 malfunction in going patient. Why we want to treat the early in class 3? We want to improve her or his quality of life, about the self-esteem. Don't want to be the monkey face. The children don't want to the friend and shout at him monkey face. Okay. And you want to redirect the growth to be from the abnormal direction of growth to be in the normal and many more for the early treatment. Because we can differential diagnosis for the class 3, we have to evaluate about the scale of problem, or the dental problem, or maybe the functional problem. And then we have to classify the problem in the maxilla, or the mandible, or the combination. That means we choose respect to the etiology of the class 3 malocclusion. So when we want to treatment plan in this case, we want to evaluate, especially in the about the orthopedic priority. We have to treat both region of space or maybe orthopedic to use the kind of treatment depending on case. I will show you about the late teen come to my clinic. 18. He has a problem about the class 2 malfunction and has a gummy small. You can see that. Mandible is slightly problematic mandible and maybe maxilla slightly problematic. And when he small, there's a problem about the gummy small. This is the occlusion in his mouth. You can see class T, K9, class T molar. And then we want to correct. Parents and patients want to do the automatic surgery in this case. We want to, as if we can do jaw surgery, okay? And we try to do pre-treatment by Invisalign first. Then we try to align and correct the malfunction. And then we use the separation jump in the Invisalign platform to correct the arch form. You can see that Invisalign has a simulation to show the patient that before and after should be that, okay? And 2 years of this treatment, this is called pre-automatic surgery. That's good. Everything looks worse. And then we send them to the surgery phase. You can see that just only one jaw. That means I plan to draw, but the surgeon so that, oh, you are treat patient in the proper occlusion, that I can really just only one jaw. And then this is the hanging, and we technique just only one jaw. After surgery, you can see that the patient improves about the smile. You can see, and then this is the occlusion 1 month after surgery. It's better, you can see that. Then you can check different between hanging and the final. And this is the comparison after surgery. You can see initial simulation and then after surgery. And this is his profile. For surgery, we have to do more to evaluate about the relapse of the surgery. So I try to follow up for a long period to make a proper operation. You can see that when 6 months progress after surgery, what happens? Anterior contact. That's the posterior open mouth. That's this is the result of the relapse. So we have to move the lower teeth back for the overcorrection. This is almost done. That I have to collect the posterior occlusion. This is almost done. Another case, 13, almost 14 years old girl. She has the face that is called the monkey face, but she has a true skeletal husky. You can see from the mandible is like formative mandible, and accident caused by this is her intraoral. And then patient and parents refuse surgery. Want to try camouflage treatment? It's my responsibility for the try to do this. You can see that we use Invisalign treatment without extraction any teeth. But you can see that the lower quantity salarial decline is called camouflage treatment. The lower anterior teeth cannot upright on the basal bone, but slightly inclined is acceptable. This is the ask form in a treat in the adolescence. You can see her profile improvement. This is how she transformed her smile without extraction. Another case, 16 years old. This is a logical. You have to evaluate about the symphysis, about the thickness of symphysis. Especially in this case, it's logical facial. That means you don't have about less bone to correct the cusky mouth vision. That means this is her mouth vision. But this is a true surgical case. But the patient refused. No. I don't want and I don't have money for the surgery. You can allow the teeth to be proper as much as possible. So okay, I will try, I will do for your best. You can see that in the upper arch constrict, right? And she has low code. So I use the Invisalign to do the lower sequential visualization without using patch. This is a her progress. You can see that I Invisalign lower second molar first, and then sequentially Invisalign. And then it's time for the premolar and canine and front teeth to come back to get the proper obiotic. This is her progress. You can see that initial and her progress. It's very difficult case for me because I have to re-evaluate about the bone limit in the movement. So when you have a problem about the class 3 like this, if you leave the case until the growth ends or to the adult or maybe adolescent, it's really very difficult to treat by orthodontic alone. Although we can keep it in Invisalign, but it's very difficult for you to treat. Another case for the class 3 in the team 16. He comes from another doctor. Doctor treat by extension upper two premolar and lower two premolar and cannot close the space. And class 3 still left. You can see that. And the patient wants to close the space. This is very difficult case for me, but I will try my best to do the final result for the class 3 camouflage treatment. And then, treatment I make my treatment plan. We want to sequential visualization and set the patient. This is his finishing of the case. You can see that although my result is my patient happy, I'm happy, but it's very difficult because it takes a time to get to close the space, to get the proper occlusion, to get the normal within the bone limits of the class 3 mouth vision. You see that initial, final, improved profile. So why we let the patient go to the adolescents and teen, or maybe up to adult and treat with difficult mechanisms? I saw this patient at age 7 when he came to me. You can see that anterior post 5 monkey face, and I want to try to do edge to edge. Just mean I want to check about the COCR discrepancy. He can do that. Okay? This is his occlusion about the young child. You can see that. Okay? This is the edge to edge that you can test about your patient. And then I scan, I treat by Invisalign as early as possible for the class 2. This is a problem with traumatic maxilla, hyperdivergent pattern, skeletal class 3, mild class 3 malfusion, moderate carving. You can see that. Treatment plan, we use Invisalign first to treat with the same objective. This is this screen check. You see that? We jump the maxilla forward, okay, and align the teeth. We Invisalign first only, and then this is staging of biojet, the arch development. 6 months progress, you can see that we can jump the bite into edge to edge. When we jump the patient from the class 3 into the edge to edge, there is positive open bite. Don't worry about this, okay? And then we use the same Invisalign progress 9 months. You can see we got our positive of biojet. Then further, we use additional alignment to keep the proper oval object. Okay. 14 months, we got the proper oval object that above the positive is still open, and then we try to use another set of the aligner. 18 months is better. You can see that the profile will be better. Anterior teeth into normal oval object and midline coincide together within 18 months. The X-ray check, you can change this profile from the upper maxillary intrusion to be like a normal. And this is the finishing is the retention phase. You can see that we use the phase 1 retainer also to the young child. When I follow up him, you can see that from the class T to be the class 1, proper oval object, okay, and then we wait for the phase 2 to collect the overall again. This is the arch form, and we follow up about the erection of the posterior teeth. Biomechanics tips for the class B malfunction, that you have to sequential expansion to gain the space and torque control of the cone shape, and you have to intrude and torque control of the lower incisor to help in correct the class B malfunction. Another case, older, 9 years old, class T. You can see that this child follow up since primary dentition. We use you can see in the lower arch, we use a composite on the opposite table of the E to make want to collect the anterior crossbite in the primary dentition by use the neuromuscular epithelium. That means we want the tongue to push the upper front teeth forward. But finally we failed, and then it's time for the use Invisalign first fail. Also you can see that her mother is a class T skeletal. That means we have to try class T treatment in this case. Okay? And then probably is skeletal class T with traumatic maxilla, and then upper one procli, lower one procli. That means when the upper one procli, we cannot procli more. If we procli more, we have a problem about the oval overjet relationship. So the treatment plan, we want to correct skeletal class T as much as possible and correct class T malfunction, correct the anterior cross bias, correct midline coincide together, achieve proper over object, achieve the proper insertion angle, and make it transform broader and wider to make a room space for the upcoming teeth, and obtain neuromuscular equilibrium of the oral tissue, especially in the class T patient. This is his clean check. You can see that. We also expand and then move the upper front teeth forward. Okay, and then jump. You can see that stretching, over object correction, dental arch development. In this case, because upper front teeth too much foci, so we want to try to use the face mask combination by combine Invisalign combined with the face mask to help the maxilla protrude in this case like this. Okay, so we want to move the maxillary forward. For this case, you can see that in the clinic, we have to do the additional alignment and the settings be the same. After I want to see this profile and one upper front and smile. You can see we have the puppy cheek. This is when the patient wears the face mask, the cheekbone is better, and the soft tissue will be remodeling better. That's beautiful. When we saw the lateral profile, the mid face improved better. That means we have to collect about the neuromuscular, especially in the oral soft tissue. 16 months. Okay. And additional alignment. We want to expand more and in space. And then we want to get the final outcome like this. This is stretching. You can see that from the oval change from the oval change, some teeth to be the normal into the proper oval is very difficult for in case of especially class T malfunction. So the final consideration to treat the class T regrowth, you have to stabilize function and function of the patient. And you have to adjust the occlusion of the upper and lower teeth that are looking for class 1. And adapt the occlusal plane. You have to adapt the occlusal plane and vertical dimension to allow the correct adaptation of the mandible. That means when the patient, when we treat the posterior teeth erupt, there's a posterior rotation of the mandible that will help to improve skeletal class T, right? And monitoring the inclination of the upper and lower incisor, and evaluate the extension of the third molar joint in the future. This is the final consideration of the going class T. Okay? So, for the first part of today, take home message. You have to evaluate patient in 3 planes of space. That means sagittal, transversal, and vertical. But in the growing patient, you have to implement about the 4th dimension is called time into the children. That means you have to choose the right timing for the each patient. This is the part of the growing patient treatment of the malnutrition. Secondly, Consider correction not only just about the dental or only the dental alveolar part. You have to evaluate about the state of problem hidden in each patient and improve about the neuromuscular balance or the function in the bone tissue too. That means you will build like the automatic surgery in the bone tissue. Okay, this is the very important for the going patient in the treat malnutrition. That means the third or the final I mentioned before that. The fourth dimension is the time. In my opinion, I also remember that the suitable time to treat the young children is 7-11. You remember the number 7-11 is very important. It's golden period to treat every patient. Okay? So, thank you for the part one. Okay? Have any questions? We have a gift for you if you list. We have a gift for you. Five questions. 5 questions. If you want. Because we have a spare time. We have a free time. Okay. You raise your hand and need a microphone for the.
Câu hỏi viên nếu như các anh chị nào có câu hỏi thì có thể giơ tay để em.
I can hear. Wait for the microphone, please. And there will be interpreter for the into English.
Em xin chào bà phóng viên, xin chào các thầy cô và toàn thể các quý anh chị ạ. Thì đây là một bài báo cáo rất là hay ạ. Nhưng mà em có một cái câu hỏi cho cái cây điều trị cuối cùng của báo cáo viên ạ. Em vẫn chưa hiểu cái cách mà báo cáo viên có thể kết hợp cái cụ face mask với cả cái Invisalign ạ. Thì báo cáo viên có thể chia sẻ thêm cho em không? Xin cảm ơn. Ở trong cây cuối cùng này ạ.
Can someone interpret into English for me? Question?
Yes. She wants you to explain more clearly about the last case. Can you integrate the Invisalign and face mask to treat this patient? In the last case.
Okay. Why we try to use the face mask into that case? How? Okay. Because when you planning Invisalign, you have to design the Invisalign by the shape to have a good retention of the tray, right? That means the tray in the mouth must be firmly stable. That means we put the attachment a lot in the posterior teeth, and then I cut the Invisalign to be a hook for the elastic to implement with the face mask. Okay, understand? I will go back to the slide. Please go back to the slide. Please open the screen, please. You can see from this picture, you can see that we cut the aligner at between the canine and first deciduous molar to be a hook and push the elastic onto the aligner. And the by protocol Firstly, we use a small force, like 200 gram per size, 200 gram per size. Why? This is not orthopedic force, just only about to stimulate, to make the patient's adaptation about to use, but it's not enough force to pull the mandible forward. To pull the maxilla forward. But then, when the patient use at night, 8 to 10 hours per day. And then, after that, we increase the strength of the elastic to be the 4 or 500 grams per side. That means it's orthopedic force, right? So when you want to do the case, in your cases like in Slavic, how to use the maxillary expander, you have to you have to diagnose about the transverse problem in this case too. For this case, we don't have any much about transverse problem, so we don't use the lapidational expansion. We use just only dental expansion with Invisalign first, and then it cut the Invisalign in the area behind the canine, upper canine, and use elastic. And patient wear elastic with the face mask at night time, 20 hours per day. Is this here? Is this here? Another question?
Có một câu hỏi thứ hai là
Okay.
Yeah.
Another question?
We have a question in QR code. We have a question in QR code. What is how long is the period of retention after the first phase one?
Oh, okay. How long the retention phase depends on each case. You have to evaluate. In my opinion, you have to wait for some, when you want to continue with the phase 2 treatment, you have to evaluate. Other teeth almost completely into your mouth, like the premolar and second molar. Okay, that means you have, when you want to scan in one arch, upper and lower, you have to include to align every piece within short period. That means you have to evaluate that is the suitable time. You want to align everything to be the beautiful alignment within the optimum period. That means if you just emerge into your gum just a little bit, you have to wait a lot of time, right? So when you do the phase 2 and almost finishing in the mouth, but there is low here, but there is space left in any way. You can move the teeth out together within the 1 year. I think it's very suitable time. Okay? That means almost every teeth completely belongs into the oral cavity. Okay. Good question. Another question? Each question you will give one gift from the aligned company. You can ask for your gift. Okay.
Thưa thầy ạ, thì em có một câu hỏi là thầy có trình bày những ca lâm sàng về sử dụng Invisalign cho bệnh nhân là khoảng tầm 7 tuổi đúng không ạ? Vậy em có một thắc mắc là đối với những cái trường hợp nào thì mình nên ưu tiên, bởi vì có những cái khí cụ cơ chức năng ví dụ như myobrace hoặc là những cái khí cụ mà liên quan đến chỉnh chức năng cho bệnh nhân về môi má lưỡi ạ. Và so với Invisalign First thì đối với những cái trường hợp nào thì mình nên ưu tiên sử dụng Invisalign First, và đối với những trường hợp nào thì mình nên ưu tiên sử dụng những cái khí cụ về cơ chức năng hơn?
Okay. crazy.
Bắt đầu bằng sự compare between the malfunction appliance and Invisalign appliance. What is the advantage and disadvantage of each appliance? Malfunction appliance like
Oh, I know.
vibrating.
Okay. Forget about the cost of the appliance, but about the Invisalign first. You can move teeth, that means dental alveoli, and you can collect skeletal relationships within the same appliance and sequentially. But when you use some functional, myofunctional appliance, it's like one appliance fit out. It's not good. I think not, but for the Invisalign first, you have to scan and treatment and evaluate in each case. And we have feature to collect both skeletal and dental alveoli for the child. That means it's reasonable. In my practice, from the pediatric dentist to nowadays as an odontologist, I never been used the appliance that have not good enough outcome. Because I respect to the parents, I respect to the child. I want the optimal outcome with the excellent result for the child. Because I respect to the child. So I do my best with the best appliance, with the best diagnosis, with my best experience for my patient. So another appliance with my evidence-based practice, I will not use. I don't treat the patient by the money. I treat the patient by my heart, by the result. You can see from my case, I treat with my heart to get, I think our children is my child. I treat them the best with the best appliance. That can be nowadays. Just be Invisalign first. Okay, right? Another question, because we have all enough, no more time. It's time to take a break. Okay? How many? Time to break. Okay. Or 15 or 30, okay. Take a break and go to the exhibition and you can see a lot of pictures. And we have a part